Institute and moderator for today's webinar. On behalf of the IJIS Institute, I want to welcome everyone to this Corrections Information Sharing webinar, the third in a series of monthly webinars featuring the United States Department of Justice, Office of Justice Programs, Bureau of Justice Assistance funded Innovations in Corrections Information Sharing. The previous webinars featured the Hamden County, Massachusetts Inmate Reentry Exchange and the Pennsylvania County Commissioners Association Unified Case Management System. All these webinars are recorded and available on the IJIS website, and links will be sent to all registrants of the webinar. As you know, the lack of information sharing between corrections and community-based service providers is a common problem that inhibits continuity of care and successful reentry of offenders returning to our communities. Sharing information about these offenders, risks, treatment needs, and programming received while incarcerated is especially important for offenders with substance abuse and mental health histories. Today's webinar, Reducing Recidivism by Sharing Substance Abuse and Mental Health Information, is about a project in Alabama where they're using information sharing technology to solve this problem. The project is known as the ASSURE project. ASSURE stands for Alabama Secure Sharing Utility for Recidivism Elimination. We're very lucky today to have three expert presenters who designed and implemented this project. On behalf of BJA and the IJIS Institute, I want to say that we really appreciate their willingness to participate in today's webinar. The ASSURE project has rightfully received much attention nationally, and we are sure you will benefit from the experiences that they've had implementing this project. The first presenter is Richard Fiore. Richard is the ASSURE project sponsor for the state of Alabama. He will kick off the webinar and provide an overview of the ASSURE project. Richard will discuss the reasons ASSURE was developed, the business issue ASSURE was designed to address, and the partners involved and steps taken to get the project off the ground. Richard will be followed by Becky Goggins, who is currently the Director of Law and Policy for SEARCH, the National Consortium for Justice Information and Statistics. Becky worked with Richard on the development and early implementation of this project before joining SEARCH. She will cover the project goals, technology and policy issues, privacy challenges, and system requirements. And our third presenter today is Matthew Hudnall. Matthew is Senior Associate Director at the University of Alabama's Center for Advanced Public Safety. Matthew will discuss the technology architecture involved in making ASSURE possible. After the presentation, we will have plenty of time for questions. So please type your questions into the question box on the webinar software, and we will ask the questions at the end of the presentation. Richard, would you welcome to begin?
Thank you, Bob, and thank you so much to IJIS for the opportunity to present this webinar today. IJIS has been a tremendous partner in Alabama in the 10 years that I've been involved with state government. Of course, not just here in Alabama, but nationwide. Of course, Director Emeritus or Dr. Emeritus, whatever Mr. Wormley's title is, y'all have been a tremendous resource for us, and we really appreciate your support and all the help you have given us. Of course, we also have to thank BJA and the folks there who have really cultivated a spirit of innovation and cooperation and collaboration and really doing more with less. The standards that they have embraced and really encouraged folks to use are something that we have very much taken to heart, and we definitely cannot do this project without them, so we thank BJA as well. In the spirit of this season, I just want to give a warning. We did start with 64 slides, but now we've narrowed it down to 32. No, I think we're actually below 32, so moving right along into that. Why did we do ASSURE? And hopefully the slide will move here. There we go. As the title implies, the main reason is really to try to reduce recidivism. We know the acronym is a little bit optimistic. I don't think we'll eliminate it, but if we can do something to reduce recidivism, that'll definitely help in a whole lot of ways, to reduce the amount of criminality we have here, and as the case is in Alabama, and we're sure in many other places, to help save money, to make the best use of our resources, and to get the best treatment for folks who are going through the system and who may have substance abuse or behavioral health issues. More specifically, some of the business issues here, I know Becky can give a lot more insight on some of these, but the basic one was that we do have had a lack of information sharing relative to the offender's substance abuse and mental health diagnosis and treatment histories among the agencies involved, and the ability to have that more accurate and complete diagnosis and treatment information is really going to be critical to avoiding a lot of reentry and maybe bad information that may get into the system. I think Becky and Matthew may get into more detail about that later, but that is one of the first reasons. Of course, to improve the continuity of care as folks move through the different systems. And then also once people are released out of corrections and into the community. You want to add any of that one? Okay. We mentioned the way that the IJIS and BJA have really encouraged folks to find some technology, standardize it, and make it something that's reusable, and I guess the word is extensible. But we really do look at, and we know that technology is a means, not an ends. So the technology component of this is, yes, we have to create a secure web-based portal to share appropriate information regarding clients, probationers, and inmates. And since Becky is right here, and I know that policy is definitely, or privacy is something she is very much into, I guess we should add on there that this all has to be done in a very secure, private way that complies with all applicable laws and restrictions and all those very important things. Who's involved? Our Alabama Department of Mental Health, our community mental health centers, our substance abuse contract providers, our Board of Pardons and Paroles, and our Department of Corrections. One thing just to note here, and it can't be emphasized enough, is how critical it is and was to the project even getting started to have sponsorship from the executive level. You know, we're very blessed in Alabama to have people in our cabinet who really have the attitude of, look, we have some common problems. What can we do about it to solve them? And we're very fortunate that our Commissioner of Mental Health and our Commissioner of Corrections got together and said, hey, we got a problem. What can we do to help each other? And so we started with executive sponsorship, and it's remained strong throughout, and it just could not have been done without that. Okay. Just to paint a picture of the background here, you can see that there is a majority of people who are in prisons or under supervision who have either substance abuse or behavioral health issues. And, you know, again, the emphasis that, yes, these folks will be back into your community. In Alabama, the numbers are similar, and some rough numbers. In corrections, you can see that we have a few thousand folks who have active mental health caseloads, a few thousand who are participating in substance abuse programs. And then, of course, our Board of Pardons and Paroles is responsible to make sure that once you're under supervision, that you are complying with what the court has ordered when it comes to your treatment services. Becky, I'm going to ask you if you can shed a little more light on this one, but just the way that we've moved from having centralized state hospitals to the community mental health centers. Can you shed some more light on that?
Yeah, I think that's one of the things that's important about this project, and Matthew will get into this a little later as we talk about how we do access controls and administer user accounts and do authentication. Our Department of Mental Health, and this is true across the country as well in Alabama, has been in the process over really about the last 7 or 8 years of moving from a very hospital-oriented service delivery model to a community-based delivery model. That's in keeping with, like I said, your national trends and really the best way to deliver those services to the consumers. What makes it a little challenging, though, rather than having a centralized IT staff responsible for administering user accounts and managing users and access control centrally, the bulk of care is really going out to these 25 community mental health centers who are private contract providers reimbursed by the Department of Mental Health, but not managed by the Department of Mental Health. so that was one of the challenges we faced, is how do we provision and manage these user accounts to kind of external users who tend to, like in other areas of employment, people move around and people are hired and people change jobs. So it's just one of the considerations we had to take in the design of this program.
And Matthew will give some more details about that later, but we just want to emphasize that. And also, one of the things I don't know if we covered it here or not, but you know, we're getting close to implementing the first phase of Assure. Again, Matthew provided more of the technical details on that. But as we move towards the next phase, which we'll implement over the next year, that will really give us the ability to do what Becky just described. All right, the approach we took, as we talked about, very important to get executive sponsorship. I'm sure there's some folks who are in government on the phone, and you know, one of the things that at least we've experienced and we've seen in other places is that, yes, you have to have the executives on board, but also the folks who are actually doing all the work have got to be on the same page and understand that, look, the boss is supporting this. If it's something they want to get done, let's figure out how we can all work together and actually make it happen. I don't know how deep we get into HIPAA or 42 CFR Part 2 or any of those other considerations today, but you know, one of the things that can stop a lot of these projects is that we hear about, well, we can't do it because of HIPAA, or we can't do it because of this. Well, if you have that level of executive sponsorship, it's not a question of why can't we do it, it's here's what needs to get done, let's make it happen. And to make sure that we kept that going, we did want to include as many different viewpoints and get people from several different backgrounds and responsibilities and roles involved in establishing the project governance. And that also flows into getting the input and support from the user community. You know, at the end of the day, this is a technology project to actually implement the system we're putting into place. But for anybody who's ever developed a software system, they know that's really important. I know it's probably doesn't happen often enough, but maybe find out what the requirements are before you actually start writing the code or implementing. That can save a whole lot of time and more importantly, taxpayer money going down the road. And again, one of the really positive things about using all the hard work that has been done to develop all the standards that Matthew will get into more detail about later. The next point about over-engineering by design, we know that for what Assure is accomplishing right now, it's overkill. I mean, the joke we made here, it's kind of like taking a 747 from Montgomery to Auburn, which is about 45 miles away. But the fact is, once we have this infrastructure put into place, it'll allow us to not only add more data sources, agencies, and organizations to the system, but it'll be something that can expand in Alabama and, more importantly, can be reused nationwide, of course, with applicable state laws put into place as well. Another area where groups like IJIS are just the priceless is getting the expertise so we don't reinvent wheels. Let's find the best resources we can and make use of them. And, of course, making use of proven standards and best practices. And we'll be hearing more about those later.
All right, well, I'm going to talk about some of the improvements that we're trying to address with the Assure project. One of the things we want to do is obviously improve communication among entities responsible for providing and coordinating our mental health and substance abuse services. And one of the things it's important to note, at least it's true in Alabama, a lot of times the first time a person may receive treatment or receive a diagnosis of a substance use or behavioral health disorder is upon incarceration. Sometimes that happens within a local jail. Unfortunately, very often that can happen at our Department of Corrections. So a lot of times there's really no treatment record for the people who are receiving these services until they're in an incarceration setting. Ideally, when they leave the incarceration setting, they're going to one of our community health centers or contract substance abuse providers, and a contract to the Department of Mental Health, and those are our safety net providers within the state. So the reason I mentioned that that's important, a lot of the people who are re-entering into the community, they typically won't have Blue Cross, Blue Shield, or United health insurance. They're really relying on those safety net providers. So it's really imperative, as we start this clinical record within the jail or prison setting, that information gets communicated out there to the people who will be delivering the aftercare services. And the reason aftercare is so important, and we've seen several studies that suggest that substance abuse treatment, especially without aftercare that's received in an incarceration setting, is actually more detrimental without follow-up than never having received the intervention. So it's one of the things when we talk about successful reentry, we talk about reducing recidivism, we recognize that having that continuity of care on the outside is just very, very important. One of the other kind of side effects of this, and I'll just mention it, is to increase awareness of the availability of these community-based mental health services. One of the things that we found to be kind of interesting, in some jurisdictions, the probation and parole officers and the community correction staff who are responsible for supervision are very aware of their community mental health centers and the availability of these services to low-income consumers, and other jurisdictions are not. So when Richard was talking about earlier about the value of bringing people together to discuss systems requirements and what we need this to do, we also found that there is value added in just having those communications across agencies that don't typically talk to one another, just to get a general awareness of the availability. I mean, the probation officers, I mean, this is a great referral source for their clients who may need these. So it's kind of been an interesting side effect that we've learned from doing the project. And then another thing we're trying to do is produce a more accurate and complete profile of offenders. One of the other things we learned after talking to the people, whether you're at probation, whether you're at corrections, whether you're in a community mental health center, they all have very similar intake and assessment procedures. So one of the things we're hoping to do, probably not in the initial phase of the SURE, but is to actually have the ability to pre-populate some of the things within a person's record that aren't really subject to change. Or if they are subject to change, they don't necessarily change very often. A couple benefits to that. One is just reducing staff time, doing redundant data entry or doing interviewing where you may be able to expedite this process by having things pre-populated and just verifying information. Also, from a data quality perspective, we think that that's important. This may not be the case in your jurisdictions, but sometimes offenders in Alabama aren't always absolutely forthcoming with some of their treatment history or their criminal history or their known associates and things like that. So it's also we found to the classification staff in our Department of Corrections and our probation officers that by having, it's still self-reported data, but having many data points about an individual, they really think it's going to help them improve data quality.
And just one real quick note on data quality, and Becky mentioned, one of the goals going forward will be to get the systems to populate each other. But for anybody who's done any sort of data analysis, if you have bad data going into the system, it just gets worse and worse as you go forward. And then I think Becky also mentioned some of the agencies working together here haven't typically talked to each other, but something that again, may not be true everywhere, but the whole idea of not just silos of information, and I think Becky gets credit for coming up with this term, but nested silos, where you have silos within an agency and systems that really should be talking to each other have no visibility to each other, and that really creates some real problems.
Oh, absolutely. So one of the other things we have found in Alabama, and once again, I think this is true throughout the country, a lot of times if people are leaving a correctional setting and they don't have access to appropriate behavioral health care, especially a lot of times necessary medications for certain persons with serious mental illness, there's a disproportionate reliance on emergency department services for those individuals. That is the most expensive mode of treatment delivery that you can possibly buy. So one of the things that we're also trying to do with this is it's once again kind of a tangent benefit, but long term we think it'll be helpful to the taxpayers if we can kind of cut down on that number of admissions, readmissions to emergency departments from people who've previously been in a correctional setting by getting them in touch with the appropriate community treatment providers, we think that's going to be kind of another ancillary benefit to the project. Obviously, we've kind of talked already about timely access to essential medications. And once again, the overall goal here, once again, our title may be a little ambitious to talk about recidivism elimination, but we really, really do want to try to reduce that by giving people a better chance to be successful on the outside. Here are just some of the technology and policy issues that we had to address. One was the need for a privacy and security policy to govern health and justice exchanges. One of the first orders of business was to develop a privacy and security policy to govern this project because there's some really good templates. And Global, I have to give credit to Global, and IJIS has always been a big participant with them. They have some excellent privacy resources available. However, they're very justice-centric. So we were able, but the good news is we had the template. We were able to take that as a baseline, but also incorporate some of the things needed to cover health. One of the other things we found is we need to obtain informed consent. I'll talk a little bit in just a few minutes about HIPAA and 42 CFR Part 2, which are the big federal laws that govern health data and privacy restrictions for substance abuse treatment data. However, our state laws were actually more restrictive than those, so we had to figure out a way to do informed consent. We also had the challenge of sharing credentials between multiple agencies, and of course not just corrections and pardons and paroles and mental health, the big state actors, but also those community mental health centers as well. We didn't have any way to do centralized user account information administration. Sometimes we lacked common data elements among partner agencies, so that's where things like the National Information Exchange Model was very helpful because it created a common vocabulary, so as we're exchanging information that we're able to map that in such a way that everyone knows exactly what this means when it comes to them through the portal. Obviously, we needed to combine records from multiple data sources into a common view, and obviously we had to be sensitive to clients' rights when sharing protected health information. And so just to elaborate on this just a little bit more, while Department of Corrections and Board of Pardons and Paroles have obviously some history of sharing information, they've never shared health information. And the mental health community has never really received any information from pardons and paroles and corrections. So one of the things that's been kind of a big learning curve, and one of the things that's a little challenging in developing the privacy policy, was taking criminal justice officials who don't know all the rules surrounding health and health officials who don't understand necessarily all the rules around sharing sensitive criminal justice data. That was kind of challenging. And then, like I said, one of the other hurdles we had to get over was that just instant knee-jerk reaction when someone would say, well, we can't share this. HIPAA says we cannot share this. Title 42 Part 2 says that we can't do substance abuse records. Well, that's not really entirely true. First of all, there are exemptions for criminal justice in both of the federal statutes. And even if you have state laws that are more restrictive, we found that with appropriately thought out consent policy and a way to have a repository that contains consent, that we were able to really, I'm not saying get around, but I mean comply with these laws without having a whole lot of difficulty.
But that would not have been possible if we had not started asking folks who were definitely important to the process, or who might even be, to give their input to make sure we weren't missing something.
Oh, absolutely.
And you know, and Becky mentioned the fact that Alabama's laws were even more restrictive. Of course, I wouldn't have known that, and there probably would have been somebody in the room who would have known. But again, to just try to make sure that you're getting those different viewpoints, and be sure to have not just the subject matter experts involved, not just executive sponsorship, but the IT people be privy to those conversations, and of course the legal folks as well. And that's probably the best way to ensure that there's nothing missed.
And then I'm going to wrap up, and Matthew can take over more of the technical discussion. But this is always one of the first questions, too, we get asked is we're introducing this to new systems users, whether those are our community mental health centers or people at the state agencies. Well, what's it going to take for my people to be able to utilize the system? And from the user standpoint, it is very basic. You need a computer with an internet connection. You need your own username and password as administered by your agency. You're not having to create a new one. And if you're enrolling people into the consent register, you happen to have a printer, because one of the things you need to be able to do is capture a wet signature, which isn't necessarily a legal requirement, but it's, as a practical requirement, seems to work best. In fact, you mentioned, Bob, that Hampden County had been one of the participants in this webinar, and it was one of the things that we kind of had as a lesson learned from them, in addition to how you can create a consent registry. After considerable experimentation with having clients sit next to intake workers and agree to consent, it was very awkward, and they discovered the best way to obtain consent was to print out an actual piece of paper, put it across the desk, have the person sign it, and then you can retain either as a scanned image or as a hard copy file. Whoever creates that original consent form, they just become the custodian of record. But it was kind of funny. Out of everything they tried, just the old-fashioned way worked best.
So it is amazing how sometimes that's the case, and I think, correct me if I'm wrong, but the bottom line here is, for the end user, assuming that they do have connection to the internet, they do have a computer, and they do have a printer if necessary, there's no additional cost to those users.
Right.
And just something else that Becky just mentioned about, some of the differences of having folks who are in the health domain and the justice domain. I think this came up, I've heard this in another webinar, but there's resources out there to help provide some guidance on what the different languages are that these different groups speak. One of the best ones that we've seen is from coaches. I'm sorry I don't have the link on here, but that was just very helpful to see. Here's a definition of a lot of the words that each of your groups use, so everybody can be familiar with the terminology being used. One of the other differences, just to mention that, between health and justice, at least that we found, is just the sheer amount of funds involved in developing these projects. What we're talking about doing right now, having at least 3 different agencies and several other organizations connected together and sharing data, this will all be implemented for less than $500,000. I think a recent term I heard was that's budget dust compared to some of the really big budgets you see out there. But the point is that this can be done for relatively small amounts of money. And once it's out there, the components are reusable, we'll have no cost to implement those. So just to mention that, and I think at this point we're going to get over to Matthew, because he is the technical expert here, and we can't thank our partners at the University of Alabama enough for the development they've done on the system. Matthew and his group with Dr. Parrish and Dr. Myers have been helping Alabama out for over a decade to get systems to put into place. So they have a lot of experience working with the different systems in Alabama. And, if we can have Becky, who is a huge Auburn fan, and Matthew, who is at the University of Alabama, if they can work together for a decade, surely we can have justice and health talk to each other. So, Matthew, please take it away, and let's hear about some more technical details.
Thanks so much, Richard. So yeah, as Richard and Becky just indicated, before the Assure project existed, we had multiple isolated silos of information. So it's your typical data sharing issue, right? You've got information between multiple agencies, or in some cases inside of agencies, that needed to be shared. And in order to do that, you have to set up some sort of sharing mechanism to move that data around. So we had to deal with the transfer of information. We also had to deal with how the users authenticate to the system, and make sure that we dealt with consent appropriately within the system. Now, the consent aspect of it is something that for us was indeed a twist that we weren't really familiar with dealing with, because we've done criminal justice data sharing projects for many, many years, and we've leveraged technologies such as GFIPM and NEEM in the past, but we really haven't ever had to deal with the consent aspect that's associated with the HIPAA and 49 CFR Part 2 requirements. So that was definitely a twist within this system. But at the end of the day, when you have multiple agencies involved, there's no common, easy way to share data between agencies. So we came up with the Assure framework, which leveraged a lot of the technologies that Richard and Becky mentioned, and tied them together to create a very usable system. So if we take a look in a minute about the components involved within the Assure project, basically in phase one we use GFIPM, or the Global Federated Identity Privilege and Management Program, which is basically an XML schema that defines user assertions or claims as far as the identities of the individuals involved. Using GFIPM authentication, what that allows you to do is authenticate against your local user repository, and when you go out to another site, that site can validate your identity and verify that based on a trust mechanism that's set up between the two entities, it can verify that yes, you were successfully authenticated by a trusted, what they call identity provider, or IDP, and that service provider or that site that you're trying to access can verify your identity and allow you to come in or use assets within that site. So within phase one, we had to map the roles and attributes that were contained within the user repositories. In this case, for the agencies involved, they all had Microsoft Active Directories. So we took the attributes and user security groups that existed within their Active Directories, and we mapped those to GFIPM claims or assertions, so that when an individual authenticated, their back-end identity provider would create a user assertion that contained all the relevant information that subsequent parties down the line needed in order to verify the identity of the individuals. So we created the identity providers. We also leveraged NIEM, the National Information Exchange Model, and we took the source data from each of the three parties that are involved at this stage, and we mapped their source data elements over to a common NIEM schema and created a IEPD, or Information Exchange Packet Document, for taking the information and putting it into a common XML schema. In order to move that XML data around, we had to set up multiple service providers that acted as data brokers for each of the agencies involved. Now, these service providers also had what's called a sorry, I've got a little cough here, a policy enforcement point, or PIP, and that policy enforcement point takes the GFIPM user assertions and it looks at what policies that the agency has in place and decides whether it's going to return back the data based off the GFIPM claims that come into the service provider. So a good example of that is, let's say the Department of Mental Health was comfortable sharing certain information fields to law enforcement, but not other fields unless the individual was a sworn law enforcement officer. The GFIPM user assertion would contain a field that indicated whether the individual was a sworn law enforcement officer or not, and mental health could then make a decision at their service provider level at the policy enforcement point to enforce the policy that they have in place, whether to return the associated data elements or not, depending on what sort of privileges or roles, or in the case of GFIPM, they're called attributes that the individual has. So we tie all of this together in a centralized portal with a centralized login mechanism that becomes the Assure portal. So that's what we're doing in phase one of the project, and phase two of the project extends that to a newer mechanism called trust marks. It's basically a continuation or kind of an amalgamation of GFIPM and NIEF, and turns them into something called a trust mark. And we're going to leverage trust marks within phase two of this project. So to look at the overall architecture of the Assure project, basically over here on the left side of the diagram, you have your Department of Correction users, your mental health users, and your partner parole users. And all of those users will go into a centralized website, the Assure portal. And the login module for the Assure portal will take the user's credentials, and based off the user's credentials, it will send the user's credentials to the to the identity provider service, web service, at each of the three corresponding partner agencies. So in the case of a mental health user, the mental health user will log in. They will send a web service query to the identity provider service, which will then create a GFIPM compliant user assertion, which will return back the GFIPM user assertion to the login module. And then the Assure web portal will keep that login credential cached for subsequent queries based off what that user needs to access. So after the user is successfully authenticated, in this case the mental health user, the GFIPM user assertion would then get passed on to each of the other data providers for when that user is searching the system. So the mental health user, if they needed to search Department of Corrections records, they would go out and use the web interface of the Assure portal and make a query out to the data provider of the Department of Corrections. That data provider would take the GFIPM user assertion that was originally created by the identity provider of mental health, and it would validate the identity of the individual at the data service provider level. And after it's validated the identity of the individual, it will then enforce whatever policies the Department of Corrections has regarding the dissemination of their data. So that's one big difference about this data sharing within this project versus traditional data sharing. Information is actually filtered at the agency level based off of policies that they enforce at the agency. So if an agency doesn't want to share certain information with individuals who are not doctors or sworn law enforcement officers or any number of user level attributes, they can enforce those policies before the data ever leaves the constraints of their agency. So moving on to the next slide, we see this is an early version of the Assure portal. It's still in development, as Richard indicated. We're looking to do a pilot launch in mid-April. But after the user is successfully authenticated to the system, what they do first is they search for an individual based off of key demographic identifiers. So in this case, they would have typed in John Doe, date of birth of January 18th, 1980. It's indicated that they're a white male and done their inmate identification number. And using that information, it will then do a simultaneous search out to all of the data providers that exist within the system. So in the case of this slide, it would search all the data providers over here on the right side of the slide. And it goes out and searches and tries to find a unique individual that corresponds to the information that was entered. If the information or if an individual is not found, because they didn't have a consent file on record, then the person who is doing the search has the option, as Becky indicated earlier, to create a new consent form for that individual. So before any information is ever disseminated out of the Assure system, the individual has to sign a consent form that indicates the appropriate dissemination of the data within the system. So backing up a slide, not only do agencies control the dissemination of data within the Assure system, but the individuals who are on record within the system have to provide appropriate consent for data for their information within the system, and they have the option to do individualized consent. So if an individual is going to see a mental health worker and they're filling out a consent form, they may say that they're comfortable only with disseminating their Department of Corrections information over to the Department of Mental Health, but not vice versa. Or they may want to say they're comfortable with including mental health information and pardon parole information, or any subset thereof. So the individual who is actually filling out the consent form is allowed to appropriately denote their comfortable dissemination of data. So we enforce the policies of the dissemination of data at the agency level, but then we also enforce them at the Assure core level. So the central module within the system, basically it's going to take the consent documents that were created by the individuals or that were signed by the individuals and enforce those consent policies before the information is ever rendered out to the users who are using the portal. So in the case of an individual who had already had appropriate consent on file, we see at the bottom that they'd have the appropriate search result for the individual that they were looking for. If we clicked on the details link for that individual, you get kind of a generalized patient summary, and this is all just mocked up data here. But we see at the top you've got some general demographic information about the individual, and these screens are still going to be customized further as we get feedback from the actual practitioners out in the field. But in this case, we've got the overall demographics information at the top, and we see that for this particular individual, it looks like they had 2 Department of Corrections records, that matched and that were appropriately returned back to the system. And we see that they had 2 mental health records that were matched as well and returned back to them. And all the fields that we have here right now are going to be further customized, like I said, as we work with the practitioners to identify what the appropriate information at this level is to return back to the users of the system. So from this level, the individual can then click on each individual record within the system and get a further breakdown of the specific record. Now, I know this is rather hard to see based off the zoom level of it, but this would, if the individual clicked on a specific Department of Corrections record, you could see the information was returned out of the Department of Corrections system after the policies of the Department of Corrections were enforced and after the policies of the consent of the individual were enforced as well. So in this case, there may be additional fields that the Department of Corrections has on this particular individual, but their policy enforcement point would have chosen not to return some of those fields based off of the GFIPM user assertion that was passed to them in the original query. So in this case, we'll see there's some general inmate information. We have some sentence information of the individual, but the most significant portion of this is the information at the bottom, and that's the intake questionnaire, the medical intake questionnaire that was actually done at the point where the individual was processed through intake at the Department of Corrections. We see any medications that individual denoted that they were taking at the time. We see the mental health questions and history of the individual, as well as other fields that are pertinent to mental health information that the Department of Corrections has chosen to be able to disseminate to mental health and pardon and paroles. So moving forward, similarly for Department of Mental Health, we see if we clicked on one of those records at the main level, we also have information available from their system. And we're working right now to get lookup tables so we can appropriately map a lot of these lookup fields to meaningful values. For example, I'm no expert in medical diagnosis codes, but I'm sure V71.09 probably means something in the diagnosis manual. So we're hopefully going to get the clean textual-based descriptions of those appropriately mapped. So then we'll be able to return that information to this centralized screen as well. So moving forward, some of the attributes that we collect for individual users. So these are the required attributes that are stored within the XML GFIPM user assertion. So we obviously have to have the ID of the individual, and we have to know what identity provider that this GFIPM user assertion came from. We need the first name and last name of the individual, the phone number, email address, and who the employer of the individual is. So this is all information that would flow all the way down to the data query point at the individual agency, whether it be Department of Corrections, Pardon and Parole, or Mental Health. So they have the ability to enforce whatever policies that they want off of these key level attributes, or if nothing else, they have the ability to log the data query and the data pool within their own systems. Other attributes that we collect about individuals, we collect their organizational category, the electronic authentication assurance level, and the identity proofing assurance level. We also collect other information about the user that weren't necessarily needed for this project as it exists within this phase, but as I indicated earlier, we're looking to, in the second phase, add trust marks to the system, as well as Becky indicated earlier, expand the system out to mental health to other mental health providers. So we have fields like whether the individual is a sworn law enforcement officer, public safety officer, the originating identifier, so the ORI code that's pertinent in the law enforcement realm, and as well as the 28 CFR certification indicator for the individual, whether they've been appropriately trained or not. So, yes?
Just one thing to add, if you can back up that last slide again. That last set there where you came up with the additional attributes, we're looking forward to some future uses. Again, we can't thank Search enough for the help they've given us to come in and facilitate some of our discussions among the different agencies and folks from a lot of different areas of expertise. I don't think that some of these would have surfaced without those discussions taking place. And we had hours of intensive discussion to come up with some of these other bits of information that might really be helpful going forward.
Absolutely. Thank you.
Yes, sir.
So let's look a little bit at the interoperability challenge. So basically, NIEM, the National Information Exchange Model, addresses the way that the data is stored and interpreted amongst different systems, because you're taking your data elements and you're mapping them to a common XML architecture. So that handles the way that the data is transferred throughout the system. The GRA, the Global Reference Architecture, deals with appropriate, excuse me, basically appropriate system architecture. So it defines the way in which you're going to transfer the information that was appropriately mapped within NIEM. So you have your common XML schemas that are within NIEM, and you have your GRA reference architecture, which addresses the web services and communication mechanisms to deal with the different technologies. Privacy and technology, and that's where the GFIPM and trust marks really come into place. So the ability to disseminate and trust information between systems without having a centralized system core is really the benefit of GFIPM. If you think of all of the endpoint connections that are needed, as you add additional parties to a system, it can grow exponentially. And that's one of the benefits of GFIPM, is basically allows a system or overarching architecture of trust to exist within the system. And then basically pervasive across all of these mechanisms are policy, best practices, governance, and experience, which transition the scope of all of them. So we feel that the technology stack that we've leveraged within the Assure project has definitely addressed and solved these common data sharing issues. And we couldn't have done it without the use of global standards, right? So the link here provides a link out to OJP for their best practices and standards that were implemented throughout the system. And I think, yes, it looks like Becky or Richard, do you want to take back over for just a second to cover the common use cases of the system?
Yes, sir. Thank you, Matthew.
No problem. Thank you.
One of the things I wanted to mention to the audience, there's a very, very good publication, and even when I'm not on the phone with IJIS, I brag on this publication all the time. But IJIS and the Urban Institute developed a document called Opportunities for Information Sharing to Enhance Health and Public Safety Outcomes. The links are available there at the bottom of the screen. They may be a little difficult to read, but I'm sure that Bob or someone from IJIS will make them available, and in fact they're out there on the IJIS website, I believe. But one of the things we identified from that document were some use cases that we thought were really applicable to the Assure project. And so where you see these bullets and you see the number in parentheses, that corresponds to the IJIS Urban Institute's use case number. And really I just wanted to point that out, because if you're interested in Justice to Health exchanges, I kind of see that as the definitive work that's been done on that to date. And if you want to be able to provide no more than, say, a 25-page summary, more for executive sponsorship, even if someone will just take the time to read the executive summary of that, it's really, really helpful, I think, in terms of identifying the various benefits to these type of exchanges.
I don't think there's a more dog-eared, marked up, and posted document I've ever had. It is exceptionally good.
And so one of the other things we wanted to talk about were the current status and the next steps. Right now we're in the process of doing our interagency data exchanges. We're in the testing phases. The working system should be online by mid-April. This will be...
I think the slide's coming up right now.
You know, like I said, we hope to have the working system to be available really for more user acceptance testing, not full production by mid-April. as Matthew kind of mentioned, we'll be doing system tuning and making improvements over the next several months. So once again, this is kind of, I would call it a soft launch of the Assure portal, but really to get some user feedback when they're actually out there using it in their offices, in their work environments, not just kind of looking at screenshots and looking at test data, but what we expect to be refining this in the upcoming months. One of the things you may have noticed if you looked at Matthew's diagram is we really didn't have any data set from our Alabama Board of Pardons and Paroles. They are actually in the process of implementing a new records management system, so that'll be one of the next steps in the upcoming months is to bring their data online so they can also be a source of data as well as a consumer of data for the Assure project.
And just one thing that is probably helpful to note there, that is a new system that's being implemented, but by and large it's a commercial off-the-shelf system. But we did bring the developer of that system to the table. They sat there with us as we're going through the discussion I mentioned earlier, so they could hear from the different users at the different agencies and find out exactly what would be required, again, before they implement the system. But they didn't develop it from scratch. They were able to use the system they already had, and using the input from those discussions, find a way to adapt that system to the use that pardons and paroles needed.
And of course, as Matthew mentioned, we'll also be developing the Trustmark framework over the next year. And once again, we're really excited about that because that really helps us with the challenge of managing those external users where we don't really have a centralized Active Directory store. For the time being, Department of Mental Health is willing to provision user accounts to their community substance abuse providers, and but they're really not set up at their help desk just to manage this really statewide network of a whole lot of private sector contract employees. So for testing purposes, they're going to provision and manage those, but really Trustmarks are going to be the key to making that work seamlessly. That
was kind of an unwritten agreement from the CIO at the time that, yeah, we can do this, but if we're going to start adding a lot more folks, y'all got to find a better way to do this. So our friends from the Georgia Tech Research Institute, they are the authority on Trustmarks. They developed it, and they'll be helping us as we move into the next phase over the next year.
Also, we're exploring adding additional data sources. As Richard mentioned earlier, this really is over-engineered for right now data sharing really between only a handful of actual data repositories. But some of the things we've talked about, the people who are moving through our correction system, they may also be receiving services from our Department of Human Resources by way of TANF or SNAP, or they may be receiving service from our state Medicaid agency. It's unclear if we would actually be able to share with those if there'd be a willingness, but it's a lot easier, I think, to convince people that sharing is the right thing to do. If you already have this trust fabric between other state agencies, sometimes I think it's a lot easier to get people to come on board once you have an operational system rather than this hypothetical, hey, will you work with us to try to stand this up? We can point to here's our success, here's how we're securing data, here's hopefully by then we'll say here's some success stories that we've had.
And I mean, Becky, I think speaking from experience, we took on one of the most probably sensitive areas by going with substance abuse treatment information, but if we can do that, maybe that's kind of the worst case and we can make things easier going forward.
Oh, absolutely. And then one of the things I want to talk about just a little bit in terms of our project assessment, if any of you who work with Bureau of Justice Assistance grants knows a lot of times they want some metrics and some outcomes that we can report. So the kind of things we'll be reporting are really pretty basic at this point, such as the number and types of agencies and partners we have participating, how many of the global standards package components we're using when we implemented, number of new policies and procedures, the number of information exchanges, number of data sources, all of that kind of basic, I call them kind of the counting measures that are pretty easy to come up with. But like I said, ultimately where we want to go with this, but we're going to have the system in place with some time. But eventually we'd like to see, hey, did queries that originate out of Assure, if you look at these people 1 year, 2 years, 3 years down the road, what's there an impact on recidivism? I mean, we have really good baseline numbers, so it would be interesting years forward to not just kind of do these counting metrics, but maybe do some effectiveness measures as well. And just to kind of start wrapping up so we can open for questions. One of the things also we wanted to talk about the lessons learned. First of all, I guess the good news, what went well and should be repeated in future data sharing initiatives. The things that I would say really, really worked well, one is by having the relevant agencies come together, not just from the executive level, but the line staff as well, to really inform the process. And obviously, utilizing the global standards, I think, helped us really speed up the process for development, because there was just a lot of stuff that we really didn't have to reinvent. We were just able to grab a reference architecture or take the name components and map our data to it. So I think those are the things that were really helpful. In terms of anything that went amiss,
did you have something you got to add there? Because
yeah, I mean, I don't really have any specific example other than things always take longer than you think they're going to, in terms of everything from contracts to memoranda of agreement.
And Bob mentioned this right at the beginning. Up until not too long ago, Becky was the person who's really behind making sure all this actually happened for the state. And we've just had some changes from an administrative side, but we've been able to keep, because of support again from the executive sponsorship, and really thanks to a very understanding state contact and our friends at BJA, who understood the situation going on and have been very willing and able to work with us as we've gone through some of the changes we've had. But we're still basically on target. But like Becky said, just expect the unexpected. I mean, fortunately for us, Matthew, correct me if I'm wrong, I don't think we've hit any huge technical hurdles. It's just been some of the administrative things that, hey, you can't really control those.
Yeah, and I guess that leads into what would you do differently next time. It really is maybe incorporated, and it's just the nature of bureaucracy sometimes, the nature of state agencies moving slow, and maybe build a little bit more lead time in terms of when you're doing an implementation timeline. I think we were more focused on the technical piece of this when putting together, kind of our Gantt charts and stuff like that, and I don't think we really allowed enough time for things to work through. Once again, the approval process with legal teams, the contractual negotiate, things like that. I would allow more lead time up front so that it doesn't appear that you're behind project schedule when you have development work that can occur pending these legal agreements.
But fortunately, we did know those were going to take a while and address them as quickly as possible.
Right.
Becky's exactly right. I mean, anticipate those are going to take longer than you think, and that there's going to be more revisions of, how many revisions did we go through with our project charter, was it?
Oh, 15.
15 different versions, but it turned out to be a really good document, all said and done.
Oh, absolutely. And as far as our insights and personal observations that can help others, I mean, I think we've talked about a lot of those today, and speaking of things like project charters and things like consent authorization forms and MOUs, I think those are some artifacts that we may have available here that I think, I don't want to speak for Richard, but I'm sure that the state would be able to share with others if it would help them, rather than having to devise some of these things from scratch, because they don't really exist. Like I said, we had lots of templates for justice-to-justice exchanges, but not necessarily health-to-justice. I same with the health-to-health. Those are very well-defined, but I think there's some things like that that could be helpful to other people, rather than you having to go do the, I mean, you're still going to have to run it through your legal teams, do your own research, but they could probably get you 80% of the way.
Well, and one of the reasons we have been able to move pretty quickly is because we've had folks who have done similar things before, and we've known, hey, let's call IJIS, let's call Serge, let's call Matthew, here's who we get contact with, and that's just been tremendously helpful. To the extent that we can help anybody else out, please just let us know. We'll be able to share whatever resources we can. I believe that may be the conclusion of the slides. Again, huge thanks to Becky and Matthew for agreeing to help out with this, and really appreciate the understanding that Search has had to allow Becky to continue her involvement with the project. Again, we couldn't have done without her and y'all's support. But Bob, I believe that's the end of the presentation, and we'll turn it back to you.
Thank you very much, Richard, Becky, and Matthew. That was an excellent presentation. I've heard versions of this 3 or 4 times, and I've learned a lot today that I didn't know, so it was absolutely wonderful. I do have a number of questions. Since we have some time left, I'd like to ask a few, and you can jump in, whoever's best to answer the question. One is, what would you say was your biggest unanticipated challenge when you embarked on this project? Was it something in the policy area? Was it in the technology arena? Or were there any?
Matthew, do you have anything that you want to add in there before we comment on that?
No, I think everything was fairly straightforward from the technical aspect.
Yeah, I mean, it was just, as we alluded to earlier, just the unanticipated changes in the structure of the project team. But again, because of the support that was there and just the professionalism of everybody involved, we were able to find a way to keep on moving forward. You know, I think right at the beginning we mentioned, hey, this is something that folks want to have done. Let's find out how we can make it happen rather than talk about why we can't make it happen. So yeah, there was definitely some challenges, but we got through them.
Excellent. Richard, you mentioned early in the presentation the importance of executive sponsorship and having been involved in other projects somewhat similar but not as sophisticated as this. I can't say that's a more true statement's ever been made. But my question is, and you've mentioned you went through some administrative changes, I guess, due to the election and so forth, and other changes in departments down there. How do you maintain executive commitment when those kinds of changes are occurring?
Yeah, and actually Becky has a really good point she wants to add on this.
Yeah, I think one of the reasons that we've been pretty successful in that, Bob, we've actually been working in the state of Alabama on something that's called the Justice Reinvestment Initiative that's been staffed by the National Council of State Governments. And we've had a significant prison overcrowding problem in Alabama for quite some time. Just this legislative session, a number of key legislators have got really interested in focusing on this issue. In fact, we had a member of our legislative delegation testify to Congress, and one part of the remarks in his comments were relative to the Assure project, and that here is something proactive that the state of Alabama is doing to help solve for this. So I think that's why we've been able to keep kind of some momentum where sometimes you have that change in leadership and it's just not a priority for anyone anymore. Without our state, the challenge with our prison overcrowding, anything we can do to help with recidivism, help with keeping people in community placement, it's very well received at this point. So I think it was kind of a unique set of circumstances. Hopefully others don't get themselves in crisis mode with having overcrowded prisons. But I would attribute that to part, at least in part.
Yes, ma'am. And again, just a tremendous support from our commissioner of mental health. I mean, he because of the experience he's had of running the center, of his legal experience and working with the court systems, it's just appreciation for how critical this can be. And that has been a way to make sure that this has maintained itself. And the fact that, you know, I don't know if it's clear or not, but Becky and Matthew and I have worked together in some degree or another for over 10 years now. And just the realization that it's kind of a natural progression of a lot of the evolution of things that happen in the justice world, and now we hope can take more of a hold in the health world. One of the other documents I know Becky and I were talking about yesterday, I think was pertaining to, was it NEAM and HL7? I mean, Bob, is it okay if she mentions that real quick? Because I think that could be pertinent to part of the discussion.
Absolutely.
Yeah, that may be something that you guys would be interested in taking a look at. In fact, it's a very recent publication from Search. Mo West actually authored the document, and it does a very good job if you're really interested in how you make this work, and especially if you're really getting into looking at electronic health records. He has a nice paper on kind of what NEAM is, what HL7 is, how they're alike, how they're dissimilar, and maybe some approaches for how you might start doing some harmonization between these two separate standards. So it's something that's a pretty new resource. It may be something that maybe after the webinar that we could send a link to or something like that. It's just this audience may be interested in taking a look at that.
And another really good example of a resource that's already out there, I think Don from your organization is on the phone, but the PDMPs and the doors that has opened for some collaboration between justice and health, I think is one of the best success stories out there too. So there are a lot of resources right there on IJIS's website as well.
Very good. Thank you for that. Another thing, I'm not sure this is a question or reinforcing a statement you made, but you talked about doing the scanned images of consent documents and making the consent specific to providers and for what purpose and so forth, and that a consent may be to share DOC information on an offender with a provider, but to not allow a provider to share anything back with the DOC and so forth, all of which is required to be able to comply with 42 CFR Part 2, as we know. My question, or sort of a statement is, and if you have any additional comment to make about it, we were involved, or currently involved in a similar mental health sharing project in the country, and the system in the state built an indicator, a block to be checked in the information system indicating the consent was recorded, which was okay from the sender's agency, but it was not going to be honored by the mental health service provider in the community because a box could be erroneously checked, and they didn't want the liability for releasing information and not having anything to back it up in their files if there's an audit, later in time. So what their solution was to scan the actual document, still check the box, but the scanned document will be available in an attached PDF, so the provider could actually print that out and put it into the case file as to protect them in the future if the system goes away or whatever. They were able to prove that there was a valid consent in there, and it sounds like you're already doing that in your system. Is that correct?
Actually, it's pretty similar. Our providers in the community, they express the same concern with a checkbox isn't going to cut it in terms of what they need in order to share information. They weren't so concerned necessarily of having a PDF copy available for their inspection prior to sharing information. The way that our interagency agreement works is that you have to present that upon request. So in other words, if I'm a probation and parole officer and I'm the one who's originally obtaining that consent, but they're consenting to Department of Corrections and mental health records as well, that probation office becomes custodian of record. They need to maintain that file for one thing, for auditing and inspection purposes, but also if there was some reason with a particular mental health provider that they could, email over a PDF. Like I said, they weren't quite as concerned, it sounds like, as they were, but they didn't want it retained for future inspection or upon request.
And Becky, one thing I'd like to add to that, the system won't actually function without consent being on file for an individual. So it's not just a box that could have been checked.
Right.
The consent process, basically the consent form happens electronically and then is printed out for the ink signature. But the information about the individual's consent is logged within the system, and that consent information is actually what is sent out to all the partner data search points. So the data is not even retrievable or searchable unless appropriate consent has been entered into the system for an individual.
Excellent. Thank you for that. A related question. To comply with 42 CFR Part 2, as you know, there's got to be a time limit on the consent that's being granted. Do you have anything in place, or have you run into this yet, where a consent's about to run out, but the services and the supervision are going to continue? Who's responsible for, does the system trigger it's time to renew this consent or it's going away, or do they sort of expire and nobody's aware of it?
It's funny, we've actually had some very long conversations on just this topic. Right now, really consent either expires at a date certain, and everyone within this particular process, I think we've all agreed to a year, and then we've talked about the need if it's about to run out, someone is still within a program, we've talked about maybe an email notification to put someone on notice so they don't show up for an appointment one day. Suddenly, this person who's been going to this office for many years, suddenly they can't receive services until they redo this form. But one of the other things we've also talked about, we have conditional expiration. So if a person's no longer on probation, subject to supervision, and the reason they provided the consent, it can also be expired for that reason. Or if a person meets all the conditions of payment, for instance, and they're released from community corrections early. So in addition to just having kind of that date consent, there's also some conditional consents that will actually look to make sure that this person, if that was part of their consent, it's because I'm on probation, it's also pulling to make sure that person's still on a probation caseload. So there's kind of a couple of different ways we've been managing that.
Excellent. I think I just have one final question here to read to you. Regarding your outcomes, you talked about at the very end capturing some of those. Will part of what you capture, the data sets, include anything like trying to track the amount of staff time that staff doing assessments or intakes might be saving as a result of having automated populated data sets, and or related to that improvements in data quality about offenders because it's being continued throughout the system instead of memory of an offender sitting at a table?
As far as the improved efficiency, that's another thing we've talked about. The problem we've run into is we don't really have a very reliable baseline on what that process is like now. We have a lot of anecdotal information either from our probation officers or intake and classification staff. I'm afraid that we haven't necessarily pinned down a way to say exactly this is on average your time. That one's going to be more difficult to prove, so to speak. But we've been thinking about it. I mean, I think what we can more readily demonstrate are the number of, say, avoided creation of brand new records and that type thing. I think that's what we'll be able to quantify. So in other words, historically in taking classification, they usually process about 1,000 inmates a month. And at this point in time, based on the number of people who go back into our prison system, gosh, about 30% of those are going to be brand new admissions. So you could say, well, now maybe only 25% of brand new admissions have to be created from scratch. I don't know if I articulated that very well, but it's not really so much as a time and efficiency study, but it's in a reduction of the initiation of a complete new record.
Right.
I think what we can measure.
And the improvement of quality. And
yeah.
I think they're in the process of implementing some automated assessment tool information as well. So bringing that online will be tremendously helpful. And just speaking of that and assessments and just the whole idea of before you assume that something hasn't been done, definitely go out there and look or talk to some of these resources we've mentioned. I know just these webinars have been tremendously helpful to us to get new information and to help us realize that, hey, somebody's already done that, or at least let's talk to so-and-so in that state. But just yesterday I found out that SAMHSA will be having a webinar next week. They have a Bridging the Gap series they're doing. I think it's maybe April 22nd. I don't have all the information, but they're obviously focused on justice to health and the substance abuse and behavioral health area. So those sort of pieces of information could be extremely helpful.
Excellent. Any final comments from any of the panelists before we wrap up?
No, just again, thank you to IJIS, thank you to BJA, and Becky and Matthew, thank you, and your organizations for your continued support. And again, if there's anything we can do to help anybody or any documents or information we can provide, please just let us know, and we'll do all we can to be of assistance.
Thank you all very much. We really appreciate the attendees' interest and participation today. And again, this link to this webinar will be shared with everybody in our systems and made available to anybody. So if you're a recipient of this webinar and want to share the link, please do so. Some of the documents that were mentioned in the question and answer period We will add the link to the information on the IJIS website, and as well as to the slide deck. So if you get the slide deck, you'll have the link to that NEAM HL7 document that Search developed as well, because I know there's a lot of questions around that issue right now. Again, everybody on this webinar will also be given an email with the link to the webinars for our IJIS correction series. It's the same link. All the webinars are located at that link, so you can skip down and select the one that you're interested in to view. Again, finally, thanks again to Richard, Becky, and Matthew for outstanding presentations and covering a topic that I think is the #1 priority among the corrections community right now to try to address, and it's only becoming more of a priority as the ACA rolls out and the additional resources through Medicaid and so forth are available for returning offenders. Please share this information with everybody that you can, and if you have any trouble finding links or the information that you heard about during this webinar, just feel free to contact Bob May at the IJIS Institute, and I'll be glad to help you out any way I can. That concludes today's webinar, and I thank you all very much. Have a great afternoon.